our first talk is related to managing hypertension in pregnancy. Very important subject. How to diagnose, when to treat, and how to prevent complications of hypertension. And for that, I'll request Dr. Tayyib Muhyiddin. He's an interventional cardiologist at Lahore, to please kindly present your talk. So Tayyib Muhyiddin, hypertension in pregnancy.
Thank you very much, Dr. Fawad, for giving me this opportunity to talk about this very important topic of treating increased blood pressure in pregnancy. Those of you who don't know me, my name is Dr. Tayyib Muhyiddin. I'm a cardiologist. I practice in Lahore. I practice at National Hospital in Defense, DHA, Lahore. So this is a topic that all of us, whether we are interventionists or general cardiologists or primary care doctors or internists or nephrologists or gynecologists that deal with this almost essentially on a daily basis, the prevalence or even the incidence of hypertension is increasing by the day in the younger population. And most of these patients sometimes fall into the category of childbearing age. And as we know, now the women are getting pregnant even in their late 30s and early 40s. So we do come across this scenario quite often for a female who's already hypertensive and now gets pregnant, or a female who develops pregnancy-induced hypertension. And then we have another set of patients who are admitted to the hospital. And I'll go through all of them during this talk. So, and we'll talk briefly about the agents that are used also. So, hypertension in pregnancy. So these data are from Western Hemisphere, and I think we can relate to it. It says chronic hypertension complicates around 3% of all pregnancies. Treating severe hypertension reduces maternal morbidity, and this is we see from the general population also. It does not necessarily mean that it could be any different from the pregnant female. Actually, it helps them significantly to have a safe, secure, and complete the pregnancy. The benefits and safety of the treatment of mild chronic hypertension during pregnancy are uncertain. The target blood pressure reduces the incidence of adverse pregnancy outcomes without compromising the fetal growth. So this last line is of very utmost importance because the mother is worried. The in-laws are worried, and the father is worried that if the medication that the mother is going to take, will it affect the fetus or not? So you have to ensure them that, number one, controlling the blood pressure would help or would be important for the fetus, for the viability of the fetus also. And we have to preserve or treat the mother. That is the first and the utmost duty of the doctor. It's just the principle that they say that you have to preserve the tree and then the fruit comes next. But if you preserve the tree, then the fruit is better also. The fruit will come, will also be preserved. So this is something that we deal with every day when a mother-in-law and a daughter-in-law who's pregnant comes to the clinic, or even the mother of the patient comes in and they are worried if it's going to affect the fetus or not. So we have to reassure them that controlling the blood pressure, or for that matter, any medical ailment of the pregnant female that needs to be treated properly. So this slide tells us about the different type of scenarios that we go through whenever we come across a pregnant female. So number one is preeclampsia or eclampsia. Now, these are the patients usually we come across. Our gynecologist or obstetrical colleagues will admit these patients to the hospital. So this is a hypertensive patient, and it has a proteinuria of greater than 300 milligrams in 24 hours. You need to have 20 weeks of gestation to qualify for preeclampsia. And unfortunately, eclampsia would, when the patient would develop convulsive form of preeclampsia. Fortunately, the proportion is less. It's 0.1% of all pregnancies, but yes, it is there, and we see this every so often. Gestational hypertension, fairly common. This is essentially the pregnancy-induced hypertension that you see that the hypertension first time appears to this female, and this happens after 20 weeks of pregnancy, and there is no proteinuria that is present. Third is chronic hypertension, that this is a female which had a blood pressure greater or equal to 140/90, which is our current guidelines that we follow for a general population, that she had prior to getting pregnant, or it was before the 20 weeks of gestation. So pregnancy-induced hypertension or anything that we would attribute to pregnancy would be something that the cutoff line would be 20 weeks of gestation. So that is an important marker for us to classify the patient, though the treatment does not change a whole lot, but from the classification standpoint, it is important, this number of 20 weeks. Preeclampsia superimposed on chronic hypertension. So 30% of the patients who have chronic hypertension and they are pregnant will develop preeclampsia. And how do we know about it? It will be heralded by proteinuria, which occurs for the first time during the third trimester, and or sudden increase in the previous level of proteinuria. That is, the patient already had proteinuria, but it would not reach to the sufficient value of 300 milligrams in 24 hours. Or it would have sudden increase in blood pressure in a woman which had previously controlled blood pressure. Other features of this condition could be thrombocytopenia, increase in LFT, especially ALT and AST. And we have all studied this as HELP syndrome in the past also. So this is, again, you have a chronic hypertension patient which subsequently develop all these features towards the third trimester. That is, the proteinuria becomes very significant, BP is not controlled, and you have increase in LFTs and decreased platelet count. So all these four different kind of scenarios. I think the gestational hypertension is the most common that we come across. Young female develops hypertension during the pregnancy and subsequently after that, 20 weeks or towards the late third trimester, or even after at the time of the delivery, you got to know that the patient is hypertensive. Or, as I said, females are developing hypertension at a relatively younger age, and females are getting pregnant in the late 30s and 40s, and we have these patients who come to our clinic when they get pregnant to adjust their medication. So chronic hypertension, as I mentioned, gestational hypertension, which will develop chronic hypertension, is the one who had a BP of more than 140/90 as the pregnancy develops, or she was taking medication previously. Gestational hypertension would be the BP that will start staying elevated after 20 weeks. Preeclampsia would be in which after 20 weeks, high blood pressure and the patient develops proteinuria, which would be greater than 300 milligrams in 24 hours. And then the HELP syndrome and the eclampsia, where the patient develops elevated liver enzymes and decreased platelets. Few words about proteinuria. So as I mentioned, you can have more than 300 milligrams in 24 hours, or you can do a urine protein creatinine ratio. So if the ratio is greater than 30 milligrams per millimole, then that would be also considered significant. If it's difficult to collect the urine for 24 hours, this is another test that could be done. Or albumin to creatinine ratio of greater than 8 milligrams per millimole. So that is again another way to check it. Or 1 gram per liter on the dipstick testing. That could be also. So all these three different criteria. One is that 24-hour that I mentioned initially, or the other ones are this urine protein creatinine ratio and then urine albumin creatinine ratio. You would see that nephrologists, our nephrology colleagues order these tests quite often on the patients who have chronic kidney disease. So switching gears, the treatment essentially stays the same. The main thing is the medication here that changes essentially with the rest of the population. So we would, first of all, especially these patients are not our usual patients that we see in their 50s or 60s. These are young or relatively young patients that come to us with high blood pressure. So we'll definitely give them advice on diet and lifestyle modification, which has a whole lot of data, and we have done a webinar on that, and I think it's available online. We did on hypertension that, DASH diet that we know less than 2 grams of sodium in 24 hours. Doing an exercise, which is an aerobic exercise of 30 minutes, 7 days a week, or 45 minutes, 5 days a week of moderate intensity. and then having a weight loss, which will be difficult during the pregnancy. All of those things definitely help with the hypertension, whether you're pregnant or it's a normal scenario, or it's a normal hypertensive patient. DASH diet, few words about it. I will just mention the one main criteria is that the sodium would be less than 2 grams. You will have increased potassium, diet rich in potassium, and will have diet rich in fiber. Now, as coming for the medication, the most important part here is that we want to make sure the BP is controlled, A, but at the same time, we want to make sure these antihypertensive drugs does not affect the fetus. So in this case, we don't want to give any agent that would have any issues with the fetus. Now, they have this class A, B, C, D different, and it's difficult to have a trial of these patients. Nobody is going to randomize, or just alone, not even randomize, just a study or a patient that they will give a medication to a pregnant versus non-pregnant female to see the effect. So it'll be very difficult to conduct any human studies. There is some animal data out there that classifies these drugs as A, B, C, D, and for the safety according to be given to the pregnant females. 3 agents that we are using these days, not back in the day, till I would say about 5 years or 10 years ago, methyl-dopa was the main agent. But at this point in time, labetalol is our main drug for choice in giving to the hypertensive pregnant female. And number 2 would be a calcium channel blocker, that is nifedipine and methyl-dopa. Now you can start with one, you can add another one, or you can, if you're stuck, then you may have to give all 3 of them. A few things about each of these medication is that labetalol here in Pakistan comes in 100 milligram pills. So maximum dose of labetalol is 2.4 grams. That is 24 pills of labetalol. So that will be a lot of medication to be given. Now, the patient may not require the maximum dose, and you can start with 100 milligram or 200 milligram TDS. So that's another thing, that you almost have to give this 3 times or at least 2 times a day. Even in the Western Hemisphere, the maximum pills of labetalol, that was for 200 or 300 milligrams. So giving this becomes difficult. And even in our regular hypertensive patient, we kind of use it as one of the 3rd or the 4th line agent drugs for resistant or malignant hypertension. But since this is for a short period of time, if it's a 3rd trimester, it's only a few weeks patient has to take. So I think it's a bearable. And even the gynecological literature at this point and their guidelines also support this to be used as a 1st line therapy. Next one is nifedipine. It's a wonderful drug. Only, again, very few brands available. Just like labetalol is only 1 brand available in Pakistan, nifedipine is again 1 or 2 brands available. One is a parent compound, that is the company that makes it worldwide, that markets it, and there are a few local companies. So it sometimes gets short also and difficult to get. And 3rd one is methyl-dopa. Again, methyl-dopa is at least 3 times or 2 times medication, so compliance becomes an issue with these things. So coming on to the patients who are diagnosed with preeclampsia or suspected preeclampsia, there are certain tests that needs to be done. As I mentioned, you have to check those certain urine proteins, and you have to check liver enzymes and platelets. So the recommendation is, as I just mentioned, that managing the weight and lowering the amount of salt, increasing a potassium-rich diet, and increasing the fiber or having aerobic exercise would tremendously help. These measures alone would shave off sometimes 5 or even 10 millimeters of mercury off the BP. And that would help us avoid the pill, or if not, at least giving a lower dose or just staying with one agent. So how do we do when you have somebody who walks in and has hypertension and is now pregnant? So you can stay with the same medication if it falls within the pregnancy safe medication, and the patient is sustaining a BP less than 110/70. If patient is symptomatic hypotensive, then you adjust those medication. Now, if the patient is not on any hypertensive medication, then in that case, you would treat if the blood pressure is persistently more than 140/90. Now, pregnant females, you want the blood pressure to have a tighter control. It's just like when we have general population of 140/90, and then you have these patients who are high-risk patients that you put goal of 130/80, which has coronary artery disease, chronic kidney disease, and cerebrovascular disease. So you'll aim for a similar kind of numbers in these patients also. So the number that's been quoted different stages were 135 by 85, 130 by 80. I would recommend definitely treat these patients a bit more aggressive and on the stricter side. So 130 by 80 should be our goal for these patients, because in between, even if the BP goes in, then if you're targeting 130 by 80, and even if the patient overshoots very occasionally, at least you will be still within the safe margin. There is some data to suggest that you can offer pregnant female aspirin, 75 to 100 milligram once daily for 12 weeks. I don't think there's a whole lot of data for this from the mother standpoint. I think this helps with the placenta and placental perfusion or the fetus. I've talked to my gynae colleagues. They routinely prescribe aspirin, baby aspirin. And most of the time, they tell us that it helps with, as my colleague, Dr. Kamran, is going to talk to you about the thromboembolism risk in pregnancy. It helps from that standpoint. And overall, they say it definitely helps with placental viability. At this point, from our standpoint as a cardiologist, we don't recommend aspirin for primary prevention. But at this point, if a gynecologist recommends it, I would never stop an aspirin on a pregnant female if they recommend it. Now, there are some specific testing. Again, I would leave it to our gynecological colleague to comment on that, that you can offer patient placental growth factor-based testing to rule out preeclampsia between 20 to 35 weeks of suspecting developing preeclampsia. So that is another way to anticipate things and be ready for it. As I said, the treatment would essentially further down would stay control of blood pressure from our standpoint. So proteinuria in hypertensive disorders of pregnancy. So proteinuria is one of the key features of preeclampsia. This is what differentiates you from the regular hypertension. And we should just not focus on the proteinuria. We need to look at the other symptoms and signs and the other investigations of preeclampsia also. And as I said, there are different tests that needs to be done. One is a 24 urine protein, and one is a ratio that has to be done for urine albumin and urine creatinine, or urine protein and urine protein and urine albumin to the creatinine. And if there is one test that is going against, then you have to look at the overall picture or repeat testing along with a new sample and make sure that the symptoms do coincide with that. So as I said, if using albumin creatinine ratio as an alternative to diagnosis, we can use that for preeclampsia in pregnant females with hypertension. You can use 8 milligram per millimole, or if the result is more than 8 milligram per millimole and you're still kind of uncertain, then you can just do a retesting again alongside the clinical review. So thank you very much for your attention. I would say the take-home message would be that we need to have aggressive blood pressure control, and the drugs that we can safely prescribe, or which are relatively safe. There is nothing which is class A in pregnant females that has to be given, would be labetalol #1, and then nifedipine and methyl dopa, which is aldomet. So thank you very much for your attention. Back to Dr. Fawad.
Sir, your mic is mute.
Thank you, Dr. Tayyab, for covering the subject very nicely. We'll try to cover the practical aspect at the end. So if any of the audience have any question, they can post it in the question answer or chat box as well. So now we are moving to our next presentation, which is by Dr. Kamran Babar, and it relates to anti-thrombotic treatment during pregnancy. So it's over to Dr. Kamran.
Bismillahirrahmanirrahim. The topic of my today's presentation is antithrombotics and antiplatelets in pregnancy. As we know, most of our patients during pregnancy sometimes come across these cardiovascular abnormalities, which entails a lot of thromboembolic phenomena. Actually, pregnancy by itself is a hypercoagulable state. because of the high clotting factors concentration, increased platelet adhesiveness, decreased fibrinolysis and proteinase activity. There is a high risk of developing DVT, pulmonary embolism, and many a times you have to give anticoagulation to these patients. On the other hand, for anti-thrombotic activity, we also see the need of antiplatelet activity, especially if the patient is having acute MI in the setting of pregnancy. We know that there is a higher mortality entailed with an acute MI when it happens during pregnancy. Most of the time, it's not atherosclerotic disease. Majority is the spontaneous coronary artery dissection because of the hormones. Exact mechanism is not very clear, but the risk factors have been seen as advanced age during pregnancy, Black race in American population, cardiovascular risk factors, and prior history of hypertension or pregnancy-associated hypertension with eclampsia and preeclampsia. So you need to treat these patients as aggressively, giving them thrombolysis, especially in Pakistan, as that becomes most of the time the first option. But in reality, the outcomes are much better by doing a primary PCI in these patients. And you can give them a new generation stent with a dual antiplatelet for 1 month. Before the time of delivery, about a week, you can stop giving them clopidogrel. The important thing is that to recognize the SCAD, and if the patient is stable, we prefer to give these patients conservative management. But if the patient is getting unstable, a more acute presentation, heart failure, the EF is pronounced because the LAD or anterolateral wall is involved, then many a times early angiography, and you have to kind of try to secure the true lumen and put a stent in to open the flow and restore the TIMI3 flow in the culprit artery. This is the list of medications that you see from cardiovascular point of view. Aspirin is pretty safe in pregnancy and lactation. The data on clopidogrel is not there, so we are not very clear about its safety in pregnancy or lactation. The direct oral anticoagulants are not recommended, and you can see metoprolol, labetalol, hydralazine. These are the medications to be given for hypertension, in which you're going to have a separate talk. From anticoagulation point of view, these are the pertinent medications from this slide. Modified WHO classification looks at maternal cardiovascular risk, and if you can see, patients who have a mechanical valve are at significant high risk for developing complications due to anticoagulation. The maternal cardiovascular event reaches up to 30%. This care of such patients should be an expert center, and we need to see the specialist cardiovascular as well as the obstetrician at least twice a month, and the delivery has to be in a tertiary care center as well. The important classification is dose dependency of the warfarin when you're anticoagulation. Such patients who need it for either mechanical valve or thromboembolic phenomena. If the warfarin dose is less than 5 milligrams per day to reach a therapeutic INR, these patients do very well with the complication rate to fetus in about 15%. Because warfarin actually, when you give as an oral medication to mother, crosses placenta, and also it thins the blood of the embryo as well. So although there is a 15% chance of fetal complication, but embryopathy is really not much reported with such a low dose of vitamin K antagonist as warfarin. But if the vitamin K dose is crossing beyond 5 milligram per day dose, then there is a much higher chance of fetal complications, up to 90%, and 10% chance of embryopathy. So the dose of warfarin is actually deciding factor when you're comparing these two strategies for anticoagulation. If you see other options apart from warfarin, unfractured heparin does not cross placenta. You can give, but the cumbersome part is the IV that you have to maintain, and certainly for this you need hospitalization, and you have to monitor the APTT every 6 hours. This is the best choice just at the time of delivery. Low molecular weight is considered to be also a safe option. It does not cross placenta, just anticoagulates the mother. But the important thing is that you can't just base your treatment on this weight-based formula, 1 milligram per kg dose of low molecular weight heparin, especially in a mitral mechanical valve. So you have to do a dose-adjusted anti-10A activity testing, and that unfortunately is not available in Pakistan. So low molecular weight becomes a difficult option for these patients. The newer novel agents, the direct oral anticoagulants, are not recommended to be used in pregnancy at this time. There's a very nice table. It might be a little difficult for you to focus, but we have to counsel the patient before pregnancy that no anticoagulation strategy is totally safe for mother and the fetus during pregnancy. But if the warfarin dose requirement is less than 5 milligram, in those patients, you can continue with warfarin for all 3 trimesters and just change to IV heparin at the time of delivery. But that's a 2A indication. And for 2B, dose-adjusted low molecular weight based on the anti-10A factor activity in first trimester, followed by warfarin in second and third trimester, is a 2B indication. But what if the warfarin dose requirement is more than 5 milligram per day? In that case, low molecular weight is something that you can rely on as long as you have a factor anti-10A activity to be monitoring facility available in your center. And since Pakistan is not available, so we kind of have to revert to a continuous dose of unfractionated heparin for first trimester, followed by warfarin for second and third trimester. And then as the labor begins, then if the patient has been on warfarin till the last moment, then you have to perform a C-section in those cases. Otherwise, about 3 days before delivery, you can admit the patient for IV unfractionated heparin after 36 hours, 1.5 days. And then 4 to 6 hours before, you can stop heparin and then continue with your procedure of normal delivery versus C-section in those cases. So the most important thing is when you have a mechanical heart valve, anticoagulation must be therapeutic. The INR has to be between 2.5 to 3.5 based on the aortic versus mitral valve. Warfarin is preferred in first trimester. Therapeutic dose is less than 5 milligram. Unfractionated heparin drip with APTT is the treatment of choice for near delivery. Low molecular weight can be used, but you can't use the weight-adjusted dose. You have to monitor anti-10A level activity, and you have to add a baby dose aspirin, 75 to 81 milligram for these patients. Thank you very much for your attention, and we will take the questions at the end of the session. Thank you.
Thank you very much, Kamran, for again a very important subject. Certainly we'll elaborate it further in question answer sessions regarding different stages and how to incorporate other things into it. Now we are going for our last talk of the session, which is mode of delivery during pregnancy. Again, a very important subject. And for that, I'll give the floor to Dr. Farhala Baloch to say a few words about that subject. Over to Dr. Farhala.
Assalamualaikum. So thank you so much, first of all, Professor Fawad Farooq and his team for giving us the chance to talk about this very, very important topic. मैं आज बात करूंगी criteria for deciding mode of delivery in pregnancy with heart diseases. It's a global issue. This is not an issue, something which is only related to Pakistan or South Asia. दुनिया भर में प्रेग्नेंट खवातीन हार्ट डिजीजेस के साथ प्रेजेंट करती हैं और बहुत ज़्यादा हाई मोर्टालिटी या शरह अमवात के साथ आती हैं. So let's move on that if a woman is pregnant and is having a heart disease or develop a cardiovascular disease, then how can we move on for a better or the safe mode of delivery and the timings of the delivery. So the guideline says that जब आप किसी pregnant खातून का with the heart disease delivery plan करते हैं, so you must actually consider the 4 points: the timings of induction, the management of labor, the delivery or the mode of delivery, and the post-delivery surveillance is very important. And a collaborative approach by the pregnancy heart team is especially recommended in those women जो कि WHO criteria में moderate to high risk में fall करती हैं. Okay. I'll not go in detail of what is WHO high risk criteria. We can all read it through the material present, but these patients especially need for the delivery pregnancy heart approach team. The timing of delivery in this pregnancy with heart disease is very, very important. As a general rule, we all should know that the induction of labor should be considered at 40 weeks of gestation in all pregnant women with the heart diseases, because this approach is provided a greater benefit in this cohort. Not only non-pregnant women, but a greater for the pregnant women with heart disease. This approach reduces the risk of emergency cesarean section and then the risk of stillbirth also. And now the timing of induction, of course, it's a general rule, but it depends on the cardiac status of the patient, obstetrical evaluation, including cervical assessment, fetal well-being, and fetal lung maturity. So again, like the guidelines are not something which should be followed blindly. Case to case, it may vary, but the general rule is that. Then they said that safe labor and induction in pregnancy and heart disease. So what is safe labor, induction in pregnancy and heart disease? There are a lot of this is kind of an obstetrical slide, but the cardiac ops talk about this, that misoprostol we all use in Pakistan and South Asia, prostaglandin and danoprostol. So this is that it can be used safely to induce labor. That means I'm talking about a normal vaginal delivery. Okay, and this is safe in the woman with the heart disease. But we should avoid the mechanical methods such as the cervical ripening or whatever mechanical method we are using if we do not want to drop systemic vascular resistance. And then again, the artificial rupture of the membrane and infusion of oxytocin, slow infusion of oxytocin can be used in women with the heart disease. So this is like just a generalized rule that what is the safe labor in pregnancy with the heart disease. So you can use misoprostol, you can use prostaglandin, avoid a lot of systemic vascular resistance drop, and you can also use artificial rupture of membrane through the Foley's catheter, or you can use slow infusion of oxytocin even in the present pregnancy with the heart disease. But again, all these rules, just I talk about induction, of course, vary from woman to woman and all these, their cardiac status and all these things. So the question now arises, vaginal or cesarean delivery. Elective C-section carries no maternal benefit. So remember, this is a very important thing, very important point, that koi bhi aaya heart disease ke saath iska to Caesar hi hoga. No. So the guideline says that elective cesarean section carries no maternal benefit. It results in early delivery and low birth weight. So the vaginal delivery is associated with a less blood loss and lower risk of infection, lower risk of venous thrombosis and embolism because the woman is early mobilized. And it should be advised for most of the women with the pregnancy and the heart diseases. Cesarean sections is considered only for the obstetrical indication, we all know. But from cardiac point of view, if the patient is presenting in the labor on oral anticoagulation, then the risk of bleeding, especially in the for the fetus, is very high, the intracranial, because you anticoagulate the woman, the mother, but you don't anticoagulate the fetus, so that you can save the mother, but there's a high risk of bleeding for the fetus. Then aggressive aortopathies, that is ascending aorta more than 45 millimeter, or severe aortic stenosis, acute interruptible heart failure, and severe form of pulmonary hypertension, including Eisenmenger syndrome. These are the indication for the cesarean section for the pregnant woman. There are certain specific conditions in which the delivery and the mode of delivery, time of delivery should be discussed. I have highlighted the few from the guidelines, for example, aortic diseases. So if the ascending aorta I talk about is 40-45, the vaginal delivery can, with expedited second stage and the anesthesia should be considered. But if the aortic diameter exceeds 45 millimeter, then the cesarean section is considered or is recommended. The valvulopathies, the aortic valvulopathies, especially in the setting of vascular adenal syndrome or type 4 or acute or chronic aortic dissection, the cesarean section is indicated. In the above cases, like when the aortic diameter is less than 45 millimeters, C-section should be considered, but it's again the individual best. in the setting of coronary artery disease and the pregnancy, we don't see a lot of coronary artery disease in the pregnancy. Maybe we overlook it, or the women do not present it. But the time of delivery must be individualized, and the guideline says that STEMI, non-STEMI should not be delayed for the delivery. Delivery should be postponed, if possible, for at least 2 weeks post-MI to facilitate maternal management, and the vaginal delivery is preferable, remember. Severe acute, there are certain conditions like severe acute heart failure or cardiogenic shock, C-section is recommended. If there's an stabilized acute heart failure, the vaginal delivery is preferable as compared to the decompensated acute heart failure, in which the C-section was the mode of choice. There is an other group, hypertrophic cardiomyopathy and pregnancy. So the low-risk cases may have a spontaneous labor and vaginal delivery. The low-risk cases are those cases who do not have an obstructive disease, who do not have severe MR, who do not have any history of arrhythmia, sudden cardiac death, do not have an ICD. But otherwise, if they are high risk, then cesarean section should be considered. If the hypertrophic cardiomyopathy mother have a preterm who is on OX, or having severe heart failure, then epidural and spinal anesthesia must be applied cautiously also, especially if they have a severe outflow tract obstruction. Okay, because we all know that hypertrophic cardiomyopathy patients have very much potential of going into hypovolemia, and they can have catastrophic effect of epidural anesthesia if not giving cautiously. So with this, I would like to say thank you again, and the session is open for question and answer.
Thank you, Farala, for a very nice talk. I think, do we have Babar with us? If not, we can, yes. Babar is with, you unmute yourself. So yes, I'll start with the sequence of presentation we did, because Tayyib is not here. So we'll discuss in ourselves that I would start pre-pregnancy. Now, what if some hypertensive female want to get pregnant? So what should be the line of action for her in terms of preventing complications? Kamran, up to you.
The most important thing is that you have to make sure that they're not on any ACE inhibitor or any heart failure therapy, because that needs to be switched before they are planning to conceive. So the discussion has to be among lifestyle choices. Unfortunately, in our cultural setup, most of the patients, when they get pregnant, their loved ones, their families start feeding them more, tell them not to move, not to walk, not to exercise, and to take everything so easy. While in the rest of the world, actually, it's totally opposite. The obstetricians don't want their patients to gain any weight until they reach the 7th month of pregnancy. They want them to be active. They want them to keep working. They want to be, watching their diet. And that actually happens in many of our villages. Our many female patients, they keep working in the crops and fields, and nobody actually knows they are expecting unless they reach very advanced 7 or 8 months of pregnancy. So I think that's the kind of attitude we need our patients to follow. The medication changes, of course. Lifestyle is something that we want to make sure that we ingrain in every patient's counseling. And the minimal amount of medication, because there is no such thing as a safe medicine, universal. Different patients respond differently to different medications. Some patients start getting a lot of swelling with very low dose, even 5 milligram of amlodipine, start retaining more fluids. Some people are salt responders. Once they cut back on their salt, they drop even more than 10 millimeters of systolic blood pressure. So I think it's based on every patient. But the important thing is to safely recognize the teratogenic medications. Don't give them statins, don't give them those antihypertensive which are contraindicated. And if they can embrace lifestyle modification, then with minimal medication, methyl dopaldomet, or with hydralazine, with labetalol, with amlodipine, this can be managed. If at some point you need to give them a beta blocker because of tachycardia, then those patients' fetal heart rate should also be monitored to make sure that the fetal heart rate does not go beyond a certain limit. And for that, CTG is done in most of the obstetricians clinics. The laying on side posture or position by taking the weight off the inferior vena cava also helps in late pregnancy. So there are little tricks and tips that we teach our patients along with the medications to maintain a healthy blood pressure all during pregnancy.
It's a very nice point that our patients who are hypertensive pre-existingly and they are planning pregnancy, their ACE/ARBs should be stopped. And other way around is that whenever you have a patient who's in her childbearing age and you have prescribed ACE/ARBs, because I'll pose this question to Farhala, how often it is in our society that patient is telling to you, I'm planning a pregnancy. Have you ever seen a patient coming with this question that I'm planning pregnancy with mild hypertension or even mild heart disease? Most of the time in a public sector hospital in NICVD, we see them in 4th month or 5th month when gynecologists refer them for any consult. So what's your take on that in terms of that? Do our patients come to us for planning pregnancy when they are on cardiac drugs?
Thank you, Dr. Babar, Dr. Fawad Farooq. So that is the challenge. You have picked up very, very important point. That's actually a challenge with us, and I think many LMICs, especially if we talk about Pakistan, that the lack of awareness and the lack of like knowledge and information regarding the diseases that can happen at any stage of life. Cardiovascular diseases is not a disease now, it's up in old age, because previously it was a concept that the hypertension and diabetes and heart attack and stroke can only happen to the elderly after they are like they have crossed their 60s and they are retired. But now we are seeing the young patients presenting with hypertension, with diabetes, with stroke and MIs also. The same lies true for the pregnancies also. So there are two spectrums. So we are actually seeing young women getting pregnant and pregnancy-induced cardiovascular diseases, and then we are seeing elderly women. So I mean, I will not say elderly. I can say like women in their 40s getting pregnant and then getting the cardiovascular diseases. So they are like, that's why the spectrum of cardiovascular diseases in pregnancy is actually increasing, not only in the Western and developed countries, but in developing countries also. Your question, it is the biggest challenge. No, I will say most of the time we see the women in their hypertension when they are already pregnant and they have conceived. We do not have that trend or culture of like going to a doctor and asking that I am having this hypertension, I'm having this heart disease, should I go for the pregnancy or not, or if I am, then what is the risk and all these things. These are not being discussed with the doctor, unfortunately. These are being discussed actually among the family members and with the neighbors more often compared. So this culture need to be changed by these kind of the webinars and educational materials and awareness to the public women and the general physicians especially, because most of our population actually read to the our general practitioners colleagues, and they are the very good source of like providing this information. Then plus the other thing is that the obstetrician have very important role in identifying these patients also. Their counseling, because most of the time they do visit to the obstetricians, and the most important point is that the obstetricians or our general physician colleagues, they do identify the cases who have already having the heart diseases. For example, someone has an ASD closure or congenital heart disease or history of hypertension in previous pregnancy, they are referred early. But even I have noticed in my practice that if a mother suffered a pregnancy-induced hypertension in a previous pregnancy, even in spite of that, they are seeing us when they are second time pregnant, instead of like following in between when they are like in their non-pregnant state. They don't follow anyone. they self-medicate themselves, or they stop medication, or they do not take anything at all, and they just feel, okay, it was pregnancy induced, so it is like finished, khatam. No. The mothers or our public and our doctors should understand that the risk of pregnancy-induced hypertension does not end with the pregnancy. It can continue with the perfurum, and it can continue with the life also. So there need to be a surveillance. So I think awareness and education is very important.
Especially at every level of care, this thing should be conveyed to the patient, whoever is in childbearing age.
Yes.
And if she is a cardiac patient taking ACRB in any form, either for hypertension or mild heart diseases like valvular or mild dysfunction, then they should, and I personally believe in not just telling the patient, his husband and family about it, that whenever you are planning a pregnancy, you have to stop this drug. I categorically, whenever I am giving ACRB to a young female, I always say in a statin. It's now we are seeing so many MIs. You can't believe it, 25, 28, 30, 32 years females with MIs, even without diabetes, because we're doing primaries. So we're getting every patient here 25, 30 MIs a day, ST elevation, and leave non-ST aside. So we see a lot of young females. So I personally believe in conveying this knowledge to even primary physicians. Whenever you see a patient, young female with ACRB on board, tell them whenever you're planning pregnancy, you have to stop this one.
There is another group. Yes, there's another group also. I think that will be helpful. There is another group of women also who are actually trying to get pregnant on some assisted method, like for example, fertility, etc. What my practice, when they used to come to me, I already because they are sooner getting pregnant in like few months or 6 months, they are on assisted treatment. So my practice is, I don't know, I think probably it's not a guideline based, or maybe somewhere some paper literature supported. I directly start them on like non-teratogenic group. For example, like the nifedipine is glucocorticoid also, that if because their pregnancy is not,
that is also a good strategy to switch them whenever they are in a state, whenever they are planning.
Exactly.
Kamran, let's move on to anti-thrombotics. Certainly, we don't have low molecular weight factor 10A monitoring. Can it be possible we can give, is it a class 3 to give a person with warfarin who's requiring dose more than 5 milligrams?
Unfortunately, in our setup, we don't have much an option. Ideally speaking, the anti-10A level for low molecular weight heparin is 0.5 to 1.2 units per ml. And for those patients, you have to give them low molecular weight 1 milligram per kg twice a day. And if the anti-factor 10A activity goes to 1 to 2 units per ml, then you can manage them with once a day enoxaparin. So that is normally what is done in the West. Over here, since we don't have this facility available in, I would say, almost all the centers that we practice, so we end up choosing either blindly using low molecular weight, or we have to give them IV heparin and follow APTT. The warfarin dose, the most common dose prescribed is actually 5 milligram. You give them once a night and you follow their INR PT in about 2 weeks, once a month. And if it is for a metallic valve, mitral valve, more than 3, you're happy with just this 5 milligram dose. I seldom see anyone who is taking lower than this dose. I mean, they might miss a day. That averages out the dose to be less, but the pill availability is 5 milligram. People who come from abroad, they have medication from the way with 2 milligram pills, 3 milligram pills. They can mix and match, and they can use a daily lower dose medication. But over here, we are, because of the limitation in the system, we have 5 milligram pill. I was 1.5 कर लें, 2 tablets कर लें, एक दिन छोड़ के कर लें, एक दिन 1.5 गोली, एक दिन 1 गोली कर लें. So that's how you end up managing INR in these patients. So
there are some local versions available of 1-2 milligram as well. I think 2.5 warfarin with the name of warfarin.
हाँ, लेकिन वो वाइडली अवेलेबल नहीं होती, उनकी अवेलेबिलिटी नहीं होती। मैं किसी मरीज को लिख के देता हूँ तो इवेंचुअली वो 5 मिलीग्राम की लेते हैं, फिर उसको वो काटते हैं, कुछ छोटी गोली बन गई, कोई बड़ी गोली बन गई। पिल कटर भी यूनिवर्सल यूज में नहीं है. So it's a very difficult challenge, and most of the metallic valve patients, we actually tell them to avoid pregnancy because that's just a Pandora box for Pandora box for trouble.
But in a way, what you concise in a summary, that it's always the first trimester and the end period, which is important in terms of switching from warfarin to any other anticoagulant and commonly low molecular weight. And most of the time, first 6 weeks or like 8 weeks, we really don't aware of the pregnancy. So that's gone. So it's almost 4 to 6 weeks period, which is threatening in first, you can say, trimester. Now something about bridging at the end.
So when a patient on warfarin is being anticoagulated therapeutically, and you reach the last trimester and it's time for delivery, these patients ideally should be planned. They should be brought in before their actual time to induce and do it in a more controlled fashion. 36 hours before this, we stop the warfarin. We start IV heparin. Most of the time, we don't have to give the bolus dose. The dose is normally 15 to 17 units per kg per hour drip. You follow their first APTT in about 6 hours time. Then you consistently want to achieve a steady state of IV heparin. So your drip should be with a, rather than the drop system, there should be an infusion pump, a syringe pump that is required. So that's why you need to manage these patients actually in a tertiary care center, because losing IV again and again, having a gap of 1 to 2 hours, drips running dry, and then resuming later does not give you a good control of anticoagulation in these patients. So most of the time, in about 2 to 4 hours before the delivery once is planned, you stop the IV heparin, you let them deliver. And then once hemostasis is secured, which is normally in the next 4 to 6 hours, then you can resume the anticoagulation with heparin and then start them on further anticoagulation with oral medication.
So it's not much difficult for our gynecologist colleague. You just have to stop 36 hours before planned pregnancy. You have to stop your warfarin and switch the patient to IV heparin, but a very persistent kind of dose, which has really brought this APTT to the targeted limit. And that just before pregnancy, 3 hours, 4 hours, you can stop that and restarts once your hemostasis is there. Now, for Hala, same patient, when to induce or when to select or when to elect for cesarean section, or just go to the, so when to really define and decide about pregnancy, this high-risk patient on anti-thrombotics.
So a very good question. Very guidelines are actually very straightforward, and even the practices are like not uniform, but we are told very straightforward thing that if a patient is on oral anticoagulation and patient is coming in a labor, there is no option for vaginal delivery. C-section is recommended after reverting the anticoagulation effect of the mother. Because as I mentioned in my presentation, that when you reverse the anticoagulation effect of the mother, you are reversing the mother, you are not reversing actually the fetus. So the chances of intracranial hemorrhage to the fetus still remain there. So mother coming on the oral anticoagulation with the
I think we are losing contact from Farhana. So there is a question after delivery. Jagdesh Kumar have asked this question. After delivery, what antihypertensive medication to switch from labetalol, methyl-dopa, nephritamine, keeping in mind the lactation? Yes, Kamran, can you answer that?
Yes, I think it's not a big trouble once the delivery has done. You can give them ACE inhibitor, you can give them ARBs, you can give them pre-pregnancy medications after that, and there's not much harm reported by lactation to these babies.
Okay, so it's all, you can switch them to the previous medication which your patient was taking. But for how long you have to, for clear-cut pregnancy induced, because if you have seen a patient, sometimes they go on with high blood pressure for months after pregnancy. So up to which time you really need to keep them on medications, or can they be reverted to normal afterward? I've seen some of them reverting after 6 months, 8 months to almost low, and then the blood pressure weaned off and it was without medication, they are like stable.
Historical data has actually shown that all these patients who develop pregnancy-induced hypertension, preeclampsia, eclampsia, they end up become cardiac patients and hypertensive patients in the long run. So we should consider these patients as metabolic syndrome patients who are ending up needing these medications as long-term. Unfortunately, we depend our medication intake based on symptoms, and we know hypertension is a silent killer. So you don't have to have a headache to have a high blood pressure. So as long as you have a discipline to monitor your blood pressure regularly, at least twice a month, and if you believe that your blood pressure without medication, with your daily routine, stresses and everything is less than 130/80, then you're better off with lifestyle modification. But once it goes up at 140/80, 150/90, and you're ending up going to emergency with 160/100 with headache and neck pressure. So I think it's these are the times in which you should plan to keep these patients on long-term medication, and whatever keeps them with a good 24-hour control with least variability, that's the regimen we want them to keep for long-term treatment.
Thank you, Kamran. Unfortunately, we lose our contact from Farhala, and Tayyib is not available. So I'm just thanking you for sparing your time for this webinar. Inshallah, we'll be, I think Farhala is with us. So
yes, I'm sorry, Dr. Fawad, we just lost.
No issue. I know you're not at your place, so it may be a difficult task to remain connected. So just a final word, and then we'll just signing off, because we already have gone through almost 55 minutes of this webinar. Yes, any final word, conclusive remarks? I
definitely would like to say that pregnancy and heart disease is a global problem. It's not something which is related to a developing or developed world. So we all should work on the same ground, and we should make this care available, not from the preconception to the entire life of a mother. So this is very important.
Thank you, Farhala. Thank you very much for sparing time, and thanks to Babar as well. And we'll be meeting again, inshallah, next month with some other topic.